So, everybody, thanks very much for joining. We have a very special talk today. Sahar is joining us from Duke, and she had done her training at Brown, then Yale, then OHSU. Was in the Bay Area for some time and is at Duke now. She's been very involved with the ASGGE in terms of teaching and education, and she's one of the course directors with the first year course that they have with the fellows. And she's had a passion for teaching endoscopy. And so we were very pleased to have her agree to come and talk to us via Zoom. A few fun notes is that her husband is from Stanford, and so she has a Bay Area connection. And she had lived here for some time, and her son was born here as well. And entirely coincidentally, both she and I both went to Brown and finished the same year. So it's kind of it's a small world that comes back to you with time. So
Yes,
Sahara, the floor is yours, and
awesome.
thanks.
John, thank you so much. And you are a testament to the true Brown graduate, total sweetie pie, medical educator, trying to make the world better. So I am super excited to talk to the Stanford family about this topic, which I'm super passionate about. And I hope this actually gives you guys some practical information. So first of all, I have no financial disclosures, but I will tell you, I am a middle-aged, short female with small hands, and I scope 3 full days a week, doing anywhere between 11 to 14 cases. My area of expertise is EMR and complicated polypectomies, and I love what I do. So today we're going to talk a little bit, these are the goals of the talk. We're going to talk about the prevalence of injury, basic common principles in ergonomics, some important gender distinctions in ergonomics, some important considerations when you're thinking about GI, and then we're going to round it off at the end with the really high yield topics, which are how do you keep yourself safe when you do colonoscopies, and how do you deconstruct it when you teach it to fellows? Now, that's what I tell you is my goal, but actually what I want to do is I want to change how you finish this talk today, maybe tomorrow you change one thing that you do and how you do colonoscopy, maybe one thing you do and how you teach colonoscopy. So I'm really interested in changing one thing about your behavior when you walk away from hearing this talk. All right, so this is gonna be a very visual talk. So we're gonna start off by giving you guys a simple exercise to look at on the screen. It's only going to take a minute. And I want you to count how many times the player in white passes the basketball. Please count how many times the player in white passes the basketball. Just keep counting. How many times did you count? Well, if you counted 15 times, great job. But did you happen to notice the gorilla that just walked through the screen? Walk right through those players. So if you didn't notice the gorilla, there is the gorilla right there. Hello. So why is Dr. Ghassemi showing you an image about the gorilla? Well, because I think the gorilla represents the ergonomics, the thing you don't think about when you're doing endoscopy. You're not focused on your body mechanics. The modern endoscopy unit, you're really focused on these external factors. You care about your patients. You want to make sure you hit your quality metrics. You get to the cecum, you find those polyps, you hit your ADR. You want to make sure your patient is safe. And we're in the business of having to keep a roof over our heads. So we have to be productive. We have to be efficient. We have to be profitable for our organizations. And a lot has changed in endoscopy since I was a fellow. So this is just indicative, the map on the left versus the map on the right of just body mass index. And as you can see, there's been a huge change in the last 15 years, just in the size of our patients from being normal weight to being obese. And you can imagine as patients have gotten bigger, they're harder to maneuver. Now, the nurses that work with us that are part of our team, their average age is 52. And nurses in general are the 5th most common injured worker, eking out construction workers. As we use propofol for colonoscopies and endoscopies, that increases our efficiency, so we're pressured to do more cases, but it also really limits the tactile feedback that we get during the cases, which actually interferes with our fellows' ability to really understand when they're looping. And it also decreases our ability to move the patients because they're quite deep in their sedation. As reimbursements continue to decline, we've got to do more within the same amount of time. And when we're not scoping, we're constantly typing away on Epic. We're constantly on our phones responding. So our hands don't really ever get any off time. And in the last 20 years, we've had a marvelous sort of like renaissance in terms of technically challenging procedures we can do. POEM, ESD, EUS, ERCP, these combined complex long procedures that take a toll out on our physicians' bodies. And so every year a survey comes out, and every year the surveys have a similar vibe, right? Whether you're an advanced, whether you're been practicing for a very long time, you're in academics, you're in private practice, or you're a fellow who's just coming out, there's this common thread, which is people are sore, people are injured, and there's a lack of real ergonomic training on the job or as trainees. We ourselves did a study where we looked at 9 different academic centers, and we had a 39% female response rate. And one of the things that we found that's been a consistent thread is gender, volume of endoscopy, and hand size were independently associated with risk of injury. So again, female gender, high volume, and small hands. So essentially me. This is what's all related to injury. So when we think of ergonomics, the definition of ergonomics is how do you make the workspace work for the worker, keep them healthy? But the reality is that's not the world we live in, right? We're doing the workaround. We're trying to figure out how to survive in the workspace and in the work requirements that we have. And so before I dwell deep down into the world of GI, I want to talk a little bit about the basics, some basics about ergonomics. So when we harken back to our med school training, we understand, hey, in order for muscles to do work, they need some things. They need to have the energy requisites, which is oxygen and glucose, but they also need time to recover and pay back the oxygen debt to basically repolarize the fibers, reset the optimal length. If you don't have time to recover and you don't have the energy requirements, you're at risk for injury. Now, there's 2 different types of works that we're constantly doing that the muscles require energy for. One type of work is dynamic work, and that's replicated in this cartoon of the person walking with his legs or running with his legs. In that work, your body's constantly adjusting your heart rate and your blood pressure to meet the demands of the muscles. So that increased blood flow goes to that area, takes away the lactic acid, and provides increased energy. That's dynamic work. Static work, however, is quite different. Static work is represented by holding that giant pile of boxes. That arm is not moving in a different rate or any different pace. It is kept in that static posture at that fixed length. And it cannot increase the heart rate or its respiratory rate in order to meet the needs of holding that box for 15 minutes or 1 hour. And so what you see is increased fatigue in the muscles, pressures in the muscles building up, which decreases blood flow, lactic acid accumulation. And so when you think about it, static work is actually harder on our bodies. So now think about what endoscopy entails, right? Standing for 10 hours a day, holding the control section of the scope, holding the shaft of the scope, wearing a 2-piece lead equipment. And all these little movements that you do with your hands, with the knobs and the shaft, all those tiny repetitive movements, your pulse is not going up, your heart rate's not going up. All of that is static work. So endoscopy in general is just one large load of static work. And I thought this was a very interesting graphic, which kind of depicts that for folks that do ERCP, right? Think about the static load of just wearing 2-piece lead. This is a thermography showing you the difference between an attending doing 3 hours of endoscopy, them at rest, and then 3 hours after ERCP. and the same with us nurses. And you can see that the lead is actually thicker in the front to protect your vital organs than in the back. And you can see that if you can see this thermography, it's a surrogate of muscle fatigue and just that static load alone just from wearing the lead. Now, there's these other concepts that are really important in ergonomics, which is your maximum voluntary contraction, which is essentially the maximum force you can generate by a muscle group. And in general, if a task requires very little of your total effort, right, very little of your MVC, you can do it for a long time. So if I'm going to hold this pencil up, which weighs nothing, I can hold this pencil up the whole time I'm talking to you, no problem. But if I was going to hold up my 12-year-old son, that's a different story. That's going to take 10 seconds and it's done. So endurance is really about the amount of time your muscles can maintain that effort before fatigue sets in. If it requires any 15% or more of your MVC, then fatigue is going to set in quicker. So a task that requires a tenth of your MVC, you can endure that 5 to 7 minutes before fatigue sets in. 20% of your MVC, and then you're going to be able to endure that for a minute before fatigue sets in. So what is the biggest determinant of our maximum voluntary contraction? Well, it turns out it's gender. So if you take a woman and a man, both 140 pounds, the woman's going to have 60% of the strength of the male. Testosterone, thicker fibers, they're just stronger, even if they're the exact same weight. Now think about that. In 2024, 2025, 21% of practicing gastroenterologists are female. So the majority of who does endoscopy and makes decisions on scopes and schedules are male. But 55% of incoming medical students are women. 38% of GI fellows are female. And 85% of your nursing support staff are female. All right, so what does that mean, right? How does that translate in terms of strength and just practicality? This is showing you a study that was done where they looked at the grip and pinch strength, distinguishing elite female athletes who use their hands for sports and who train their hands for sports and are at the peak of their performance compared to the average man, compared to the average woman. And the elite female athletes were still weaker than the bottom 25th percentile of the average male. So take it another way, this is showing you a depiction of comparing women versus men and their grip strength over decades of life. The average woman in her 30s has the grip strength of the average man in his 80s. So just think about that for a minute, right? When I come out of fellowship, out of my EUS ERCP fellowship or out of my general GI fellowship, I have the equivalent hand strength of an 80-year-old male. So for any given task, I am working harder in that task. But strength isn't the only aspect of that. I have to be able to recruit that strength. So in order for me to recruit my strength, I have to have an instrument that's in the ideal grip size for my hand. So this is showing you how if an instrument is in ideal grip size for the size of your hand, you can recruit your entire grip strength, which is 70 pounds. But as the instrument gets to be too large for your hand, you're only able to recruit a portion of that grip strength, and it can actually go down 20-25%. So now harken back to these moments where you've been training fellows and they say to you, my hands can't work around the scope. I'm really struggling to reach the dials. There's validity to that, right? If the instrument is too large for their hand, they cannot recruit their grip strength. And if the dials are hard for them to turn, there's validity in them saying that they're having difficulty doing that. This is showing you how the work on the thumb in turning the dials on the scope. The average woman, when the dial is working effectively, is using about 1/4 of her maximum voluntary contraction for her thumb. The average male is using 12%. Anything over 30%, and you're going to start to run into risk of injury. Now think about this. If the dials are stiff at your institution because they just went out for repair, or because they're new, or for whatever reason, it's going to be your vulnerable population, the person with the small hands, the woman with the less grip strength, that's going to notice that. So please don't assume you need to wait to see if the majority rules. Do all of the doctors think that is the case? Because 79% of practicing physicians in the community are male, so we have to be thoughtful about that. Now, irrespective of whether you're a man or a woman, what we do is superhuman. The equivalent work of what you're doing with your thumb is like bench pressing a liter bottle of water with your thumb. In all phases of endoscopy, even among expert hands, a third of the time, even in those folks that have done their 10,000 hours, they're outside of neutral postures, in extreme postures with their wrists or their hands that put them at risk for injury. So the bottom line here is, for any given task, women are working harder. But regardless of whether you can bench press 500 pounds or not, doing this all day with your thumbs or wearing lead all day is superhuman. You're always going to be at risk of injury. So if I was going to design the ideal instrument, I would be thoughtful about it. I would say, okay, I need something that's lightweight, that has minimal static load, that accommodates different hand sizes, not just one size fits all, that allows my body to stay in neutral so I can recruit that strength, and it doesn't require manual force to manipulate exclusively. So how do our modern scopes compare? This is an image of how far we've come in the last 20 years when you think about optics. Wow, I can tell in real time if I'm dealing with a tubular villus adenoma, if there's a zone of irregularity, if there's possible high-grade dysplasia or cancer within that lesion, because our optics are phenomenal. But how do our scopes compare in the last 20 years in terms of how the user experiences them, what they look like? Well, the design has undergone very little alteration, and the power to insert, move, give directionality to that scope is 100% manual, right? No change. All right, so we set the stage. This is what we're up against. So how do we optimize our ergonomics? How do we give you practical solutions? Remember, I'm the highest risk individual. I'm short, I'm old, and I have smart hands. I'm old, have small hands, and I'm a female. But I think it's also prudent when you tell an audience, hey, I want you to think about scoping like me or doing things like me, that I also tell you what my quality metrics are. I practice not at a VA with an enriched population. I work in a community-based practice where I do 11 to 14 cases, and in my screening colonoscopies, my adenoma detection rate is 53%, and my serrated detection rate is 21%. And these are not hyperplastic polyps in the right colon or in the rectum. These are dedicated serrated lesions. So it's important for you to understand my quality metrics are on par. All right, so I'm going to go through the guidelines for you guys, and I'm going to talk through the guidelines, but I'm going to be very honest with you. The guidelines are very limited. They just fall short. For one reason is they depend on changing behavior, right? Hey, there's smoke around you, but just maybe step out for 20 minutes and then come back in, right? They're not actually changing the exposure, what the scope looks like, but they're asking you to change your behavior, how you modify workarounds for the fact that this scope is a danger to you and is not ergonomically optimized. So I think when you think about leadership in endoscopy units, you want to be thoughtful about not only thinking of quality in terms of how your ADR is or how safe your patients are, but maybe starting to incorporate the ergonomics and the safety, how safe you keep your team and your talent in the context of how well you're doing as a unit. So, being safe when you do endoscopy boils down to trying to stay neutral. Because when you are in a neutral posture, which is basically like you're holding a tray, right? You're looking straight ahead, your arms at a 90-degree angle, your back is not bent forward. In this position, your muscles are in their optimal length, so they're going to do the same task for less effort. When you sway back, when you sway forward, when you sway to the side, when you just sway to the other side, your muscles come out of that optimal length. And now you're expending more energy for the same result. I'm paying $8 for that gallon of milk rather than $2 for that gallon of milk. And I can't think of any better example to illustrate this to you guys than the example of the cell phone, okay? Maybe all of you don't scope 3 days a week, but all of you have a cell phone. And this pictorial shows you the importance of neutral posture. The woman on the left, her head weighs 12 pounds. She is in neutral posture. The weight on her cervical spine is 12 pounds. As she starts to get distracted, tired, worried about her inbox, getting pages left and right, and her starts to do more and more cervical flexion on her neck. Once her neck has gone into 60 degrees of cervical flexion, the relative weight of her head to her cervical spine is 60 pounds, right? So if you are of the generation where you grew up using your cell phone and you have bad posture when you're using your cell phone and your neck is in cervical flexion, that relative weight that you're putting on your neck, guess what nerves are feeding off the cervical spine? Your hands, your forearms. You have numbness and tingling in your hands. Look at how you're holding your phone and your posture. These things are incredibly, incredibly important. So when we think about doing endoscopy and ergonomics, you have to work smarter, not harder, right? You need to stay in a neutral posture, and particularly with colonoscopy, that means you got to drive a short scope. Fellows get very excited when they get to the cecum fast, but they don't often get there short and fast. The most important way to protect yourself is to have a responsive scope. So how do you do that? How do you get to the cecum short? First of all, you have to remember the gorilla. You have to do an ergonomic timeout before you start the case. You have to think to yourself, is my equipment in the right position? Is my bed at the right height? You have to think about your patient when you're selecting your instrument. Do you have the right scope? Do you have the right ancillary support for what you're doing? Think about how you schedule endoscopy for your providers. I do my EMR, my complex EMRs, first cases of the day, not last cases of the day when the lactic acid has already built up and my muscles are sore. There's an intentionality there, right? For your patient, for your providers that do ESDs, ERCPs, and so forth, think about how you're scheduling them throughout the day. Are there breaks? Is there an administrative day to offload all that endoscopy that you're doing? You, as Stanford faculty and fellows, never scope alone. There's always someone in the room. Train that individual, whether it's your tech, whether it's your nurse, to understand what it means for you to be in a neutral posture and reinforce that if you're coming out of that posture. You have to start advocating for a culture of injury prevention. It's so, so important. And it is important for us to train that inside, outside of endoscopy. All right, so this image has been replicated till the cows come home, right? It's in every single document that ever talks about ergonomics. And the gist of it is you need to have the screen so that you're looking straight in front and you're not having your head in cervical flexion or in cervical extension. You need your right hand, which is holding the shaft of the instrument, to be at elbow level or within 10 centimeters. You want the bed to be maybe approximately hip height, but essentially like you're holding a tray, right? So you're not bending forward. You want to have that athletic stance, and we'll talk about that. You don't want any loops in the umbilicus of your scope. You want to have comfortable shoes on. These things are important. Now, there's a lot of numbers on this screen. Very, very busy, very, very busy, lots and lots of numbers. What do those numbers mean? Okay, guys? What those numbers mean is the top 5th percentile male who's 6'2", and the bottom 5th percentile female who's 5 feet tall, both of those people have to be able to walk into your Stanford endoscopy unit and get into neutral. So both of these individuals with their relative sizes have to be able to get into neutral. And if they cannot get into neutral, what is your short-term solution? What is your midterm solution? What is your long-term solution? Maybe you have beds that come high enough. You put tape on them, and those are the beds that go to the tall endoscopist. Maybe you have monitors that come low enough and you prioritize the short endoscopists in those rooms. But it's incredibly important to advocate for your talent. When I do endoscopies, I think about the equipment that I'm using. The image on the upper right shows you that not all scopes are created equal. The angulation is different between an adult scope and a pediatric scope and an upper scope. So if I have a colonoscopy that's referred to me that's for failed colonoscopy, dense diverticular disease, 80-year-old lady, which you can argue, why does she even need a colonoscopy? I'm going to go with the pediatric scope, right? Versus my BMI of 65 that I'm doing in the OR, who's going to have these deep folds that, you know, go down 8 feet deep. I'm going to reach for that adult scope. There's not data to support using binders, but sometimes if I think I need, you know, everything in the kitchen sink, I may consider doing that for my incredibly obese patients where abdominal pressure is not going to do anything. I'm a big believer in caps, and I'm going to go over why I think caps are very helpful. Dial adapters for small hands, there's not great data for that either, but if your physician finds that it's helpful, I think that's reasonable to consider, and they're not expensive. What I do want to draw attention to your attention to is understanding that you need to be understanding as a provider when your instrument is not working optimally. Let me explain that to you. If you're pushing down on the big wheel and your tip is, there's a lag in your tip responding and moving, or you're pushing down in your big wheel and it's supposed to go up, down, supposed to go 180 degrees, but it's only going to go 160 degrees. If your instrument is impaired, you have to compensate some other way. So guess what? You're going to compensate with coming out of neutral and your hands hurting, because that's going to be a more difficult procedure for you. It's so important you understand who audits this in your unit, how often they audit it. And if you notice that your hand is hurting and you're noticing the dial is stiff and it's not locked, you need to think about the fact that maybe that scope was sent out for repair and the scope companies made it extra tight so you didn't complain that it was loose again. And so it's really, really hard for you to maneuver. So it's very, very important for you to pay attention to these things because they have tremendous impact. Now, I do a lot of really morbidly obese patients, and with propofol, I have one shot, right? I'm not able to move these patients. And sometimes they refer to me for big polyps. If I know the polyps in the transverse colon, guess what? I'm starting them in the supine position. I'm not even starting them in the left lateral position. And I'll go through that in 1 second. If I have scope guide, which I don't, but you guys have Olympus scopes, think about using the scope guide because it'll guide where you're going to give abdominal pressure. There is no healthy way to give abdominal pressure, guys. So if you ask for abdominal pressure, you want to ask for succinct pressure. I know within 2 seconds if the pressure is going to work. If I give them a location, they give pressure and it's not working, I adjust. Go to a different location, look to see how they're giving pressure. But the bottom line is I don't have anybody hold pressure endlessly for 5-10 minutes, ever. Very succinct pressure. Very rarely, I will tell my anesthesiologist, this is anticipated to be a difficult colon. I may need this patient to turn. They're very big. Start them light. If I cannot get through that location, we are waking them up and having them physically turn before, because I don't want to put that on my team, very rarely. As a trainer and as a trainee, you need to understand where the air, where the gas and the water goes, to understand how you're going to get to the cecum or how you're going to get there short. So the images here are showing you, basically depicting to you the difference between the splenic flexure, for example, the difference when you're in the left lateral position where there's a very acute angle and it's very collapsed and you're really struggling to get through it, versus in the right lateral position where it's opened up and where the air has floated and kind of opened up that space. Another pro tip, splenic flexure is a posterior structure. If you think you're looping in the splenic flexure and you keep asking your nose to give pressure in the left lateral position, it ain't going to work. You need to turn the patient supine to bring the splenic flexure closer, more anterior, so you can apply splenic flexure. Be very mindful of that. Now, I do a lot of water-based endoscopy, And that came through my years of working at a VA. And working at the San Francisco VA, our lovely veterans did not trust the government. So they wanted to have unsedated colonoscopies. And so I got very good at doing unsedated colonoscopies. And you guys know our veterans are very tolerant of pain. But in general, what I really realized is when I use water, I can do this unsedated. I wasn't really requesting abdominal pressure. And studies have shown you require less sedation, less abdominal pressure. And this is basically depicting why, because the splenic, where you loop is the areas in your colon where it's not fixed. Ascending, descending colon fixed. Sigmoid transverse colon, transverse colon not fixed, right? They're mobile. So here the gas is moving the sigmoid colon away. Here the water is weighing down the sigmoid colon. Notice another pro tip: sigmoid colon pressure is not left lower quadrant pressure. Sigmoid colon is mobile. It can go to the right lower quadrant. It can go suprapubic. It can go periumbilical. It could go left upper quadrant. It can go in many different places dependent on the length and the redundancy of the sigmoid colon. When I ask for sigmoid pressure, I often start in the right lower quadrant because that's where I think, as depicted in this picture, that's where I think I need the pressure, to give the pressure. I'm a big fan of cap-based endoscopy for anticipated difficult colonoscopies. High BMIs where I have to go, I'm looking for polyps and there's just a lot of folds that I have to interrogate and they're very deep, or very tight restricted diverticular disease because I'm trying to spare my hands from trying to look in all these nook and crannies. Caps are cheap. If you're not going for the name brand caps, they're anywhere between $12 to $18. So think about the relative cost of a clip, right? $75 to $200. So you can use a whole day, every single case cap. You're not going to come to the price of a single clip. Caps reduce time to cecum. So they reduce exposure to injury. They also improve ADR. They're basically your retractor. So if you look at these images, here's a polyp hidden behind the fold.
614 558 4131.
And here,
Yes.
here's the polyp. So you can actually see the polyp. You can actually, rather than using your hands to hold that position, the cap comes in front of the view of the scope and allows you to hold that position. All right. All right, so now this is my favorite part, which is for all of our trainers out there, practical guidance on how to teach ergonomics to trainees, all right? So the very first question I'm gonna ask y'all is to think in your head, in the room, where are you physically standing? Are you standing in the green on the left, to the left of the trainee? Are you standing to the right of the trainee? Well, if you're standing to the left, your view is completely obstructed. You are not seeing their hand, their right hand, which is the most sensitive instrument for you to detect whether they're looping. You need to stand to the left of to the right of the trainee in order to see the right hand movement. Now, I completely get it. I have a hospital-based endo unit where there's a trash can and a red trash can, and there's the door here, and I'm scooched right next to the trash can trying to look at their hands. I completely understand how this is difficult. Very first thing I ask before I work with a fellow is I ask my fellow I'm very straightforward about it. Are you having any discomfort? Where are you having discomfort? And I look at them, right? I look at their physicality. Have you had a history of injury? Maybe they play tennis and they have elbow or shoulder injury. Are they small? Are they tall? I look at their physicality and I realize, and it's really important for all the faculty on this Grand Rounds to understand, you have a really important moment in time in this person's career because you are training them to develop habits that they're going to carry for the rest of their life. If you intervene now, before it becomes second nature, you're going to have such a huge impact on your trainees before they have to unlearn bad habits. So position yourself in a place of success to the right of the trainee so you can see their body mechanics. Ask them if they hurt. Normalize that conversation so they can be honest with you. This is basically a graphic that I've taken from a recent meta-analysis where they pooled all these surveys from different attendings on across the world where they hurt and kind of gave us a global picture. But in general, it falls into two buckets for me, right? If someone's arms and hands are hurting, I think it's related to how they're handling the scope. And I'm particularly mindful of the position of where they're holding the scope, and I'll talk through this, and whether these people are incurring high forces and looping. With the advent of propofol, our trainees have less of a tactile feedback of the patient jumping off the table or telling you they're uncomfortable. So they're struggling to know when they're having subtle loop formation. If their discomfort is in their trunk, right, in their neck and their spine and their lower back, it's somehow posture related, right? If it's related to their feet or their knees, I wonder if it's somehow related to where their water pedal is. And again, I'm not a physical therapist, but these are the things that I've noticed over the span of my 18-year career when I'm watching and training fellows. All right, so that's the image, the beautiful image, or not so beautiful image on the right is my, like my posture. But I would encourage you as faculty to pay attention to your trainees' posture. Have people pay attention to your posture. Because remember, this is the ideal world, right? But none of us live in this ideal world, right? All of us have hangups. Maybe we just had a baby and we're used to holding our baby in our arms, so we have our pelvis tilted back. Maybe we're constantly in front of a screen, and so we have this sort of cervical neck forward protrusion going on. Maybe we sort of have really bad posture and have these rounded shoulders. The point is, if you're not in neutral posture, like that first few images I showed you, your muscles from the get-go are working harder for any given task. So understanding that posture plays an important part of that, and helping your fellows or trainees get to physical therapy to help them get to where their core is stronger and their postures are improved. Now, a lot of the guidelines recommend an athletic stance where your feet are hip width apart when you're doing endoscopy. And the reason for that is you don't want to, the narrower the base of support, the more the rest of your body is going to float and move in the 3 dimensions. And as you do that, right, because you're concentrating on the procedure, your core and the rest of your body has to work even harder to maintain your posture. This is a much harder posture for you to maintain than an athletic stance. A lot of your fellows are going to start an athletic stance, but once they start concentrating on the screen, they're going to start to cave in. They're going to start to narrow in. So this right here, this is basically depicting some things to pay attention to when you're watching your trainees. The green circle is the water pump, right? So we all have these anti-fatigue mats. Mine has a drop-off that's hard for you guys to see. It has a ledge. A lot of times, if the water pedal and the mat are just at the edge of the bed, rather than the bed actually coming on to the mat, the fellow is standing on this edge, which is kind of like standing on their tippy toes, which is kind of like standing on heels, which is kind of like defeating the purpose of wearing athletic shoes. You want to be standing more in the middle of this area and draw the bed closer. You want to be standing in an athletic stance. You don't want to be in between anti-fatigue mats with 1 foot on and 1 foot off. Because again, that uneven surface is firing off sensors to your brain. You're spending a lot of energy just maintaining that posture because of the uneven surface without realizing it. These are some common cartoon depictions of what I see with my trainees, right? The image of the trainee that's on their tiptoes and maybe the screen is too low or the screen is too high and their head is in cervical extension. This is the classic, Twilight Zone of them getting sucked into the image because they're really concentrating on the bleeding ulcer, or they're really concentrating on that fold, and they're just coming into that neck coming out, right? Coming into that cervical flexion that's making their 12-pound skull feel like it weighs 60 pounds. Sometimes they're in thought and they're turning their head to the left and they're turning their head to the right. But if they maintain that posture, that's a problem, right? If their neutral posture is, hey, I'm always focusing and I'm always tilting my head to the right, then they're going to start to have pains and aches. So a lot of times when I see this activity, I simply tell my fellows, stop. Close your eyes. Where's the weight in your feet? If it's in your tippy toes, they're like, oh, my weight is in my tippy toes. Oh, my weight is in my heels. Okay, fine. Ground yourself. Get it distributed through your entire feet and then resume. And then they autocorrect. All right. So you guys I've talked through a lot of stuff with you guys. So what's wrong here with this image? All right. Take a moment. What's wrong with this person? All right. So maybe you picked up on the fact that the actual bed was too low and he's leaning forward. Maybe you picked up on the fact that the screen is too low and the screen needs to come up. But maybe you didn't pick up on the fact that a lot of times we put the patients too much in the center of the bed and your fellow is leaning forward, not because the bed's not high enough, not because the screen's not high enough, but because they're leaning forward because the patient's too far away from them in the bed. And so that's why they're leaning forward. I'm going to tell you another pro tip. All these guidelines tell you that the bed should be able to come up to 120, 125 centimeters. There's no stretcher that exists that does that, right? So there's a flaw in our guidelines, right? You're telling us to ask for this, but then when I ask for this, I'm told, lady, you're crazy. They only come to striker beds only come up to 104. So, hey, we should build stretchers that go to the height of the guidelines they recommend. All right, so I hold my scope for colonoscopies very differently than I hold my scopes for an upper endoscopy. And I'm going to explain to you why that is. For upper endoscopy, it's very much upright, that how people traditionally hold the scope. But I hold it more on an angle. For colonoscopy, I actually hold my C-scope in a horizontal plane. And the reason for that is dial access. All right. When you're hubbed at the umbilicus and you have your thumb on the dial, that's fine for upper endoscopies. Because guess what? You're really not using your small dials for upper endoscopy. It's a lot of up-down movement and torque, right? For colonoscopies, you are reaching for that dial, that left-right dial. And so when you hold the scope on the horizontal plane, look at the orange line. Look at the distance for my small hands, my thumb, to get to that small dial when it's in the horizontal plane as opposed to the vertical plane. I never have my scope off the bed. I scope with my scope starting on the bed in a C-scope position. I do this for a multitude of reasons. And one of them is because I rely on the movement of this C to give me torque. And I'm going to show you a video of that. The other reason is I am not holding this scope. I'm not carrying that weight on my right hand, which is very, very important to me. And also I'm putting the weight of the control section when I can on the buttocks or the backside of the patient. So I am offloading that static load on my shoulders. I'm going to show you a video of using the weight of bringing the scope forward and backwards. Is very exaggerated because you don't need these big movements to give directionality to your scope. So you see, all I'm doing is bringing this hand in and out, and you see the movement that I'm getting, and I can get beyond 360. I can get 720 just by moving my hand, my left arm backwards and forwards and having tip deflection. So it's important for you guys, and there's a video I'm going to show you at the end, a site to go to where you guys can get more intense training on how to do that. There's a wonderful 30-minute video through one of my mentors in Canada that goes through that. So when I watch trainees do colonoscopies, I watch the screen maybe 20% of the time. I don't even look at the monitor on insertion. I look at body mechanics and hand mechanics to know exactly what's going on in the patient. I know when they're looping before they tell me they're looping, before I don't see them advance. Why? Because they come out of neutral. Why are they coming out of neutral? Because they're encountering counter forces, right? They're going from a pencil grip position to a strangulation wrist position. They're encountering counter forces. If their nose is coming closer to the screen, if they're getting pulled in, if there's more scope in the patient, Then there's outside the patient, they're encountering counter forces. There's a large loop on the outside of the patient, they're encountering counter forces. We need to be mindful of what's happening with their hands, what's happening with their body mechanics in order to read what's going on, not just what's happening on the monitors. If your fellow has pain in their shoulder, in their forearm, in their wrist, in their right hand, where they're controlling the shaft, you need to pay attention to the idea that they're looping and that they're starting with the scope hanging off the bed. Here I am, here's the scope off the bed, right? From the get-go, my elbow and my shoulder is protracted, meaning away from my trunk. My elbow is behind my back, okay? When your elbow comes behind your back, game over. Not using your trunk, you're not using your core. Everything you're doing when your elbow is coming from behind your back is driven through your arm. You are not at all using the rest of your core, right? So you're basically setting yourself for injury. So part of the reason why I have that scope in front of me is because I can keep myself in that neutral posture where I'm not putting my elbow behind my back. Now, sometimes I'll have to, right? Sometimes I'm going to have that crazy case, but I'd rather do it 10% of the time than 90% of the time. I always have my fellows do a mental check when they get to the cecum. You get to the cecum, you close your eyes. Where is your weight in your feet? Where are you feeling your pain? Where is your body posture before you start doing your withdrawal? Because it's a reset. Can you rest your arm on the left on their patient's body while you're doing the endoscopy on withdrawal? I think it's also really, really important you understand it's not just when you scope that you're getting injured, right? Look at the whole of your unit. Do you have endoscopy doors that separate all the pre and posts where the patients get ready for their procedures, which are heavy glass doors that weigh a lot to pull? Is the door in and out of your endoscopy units automated, or are they heavy iron doors that you have to pull that's hurting your right shoulder? Are you in this position at home when you're not doing endoscopy or when you're at your kid's soccer game? Is your workstation poorly designed? Are you able to keep your wrists in neutral? This image I'm showing you because every keyboard that we're given has a number pad, but you do nothing with that numbers pad other than keep your arm in your shoulder and abduction, which is not healthy for keeping your shoulder in neutral. So guess what? When I work from home, I have a split keyboard with no number pad because I want my right arm as close to my keyboard as I can possibly keep it. I don't want it extended any further. When you are in between cases, stretch out your hands, right? You're constantly in this position, stretch it out. Take a rubber band, hair rubber band, whatever, stretch it out. Keep your arms stretched out, roll back your shoulders. Basically, you're doing the opposite of the pose that you were in. So if you're in like a forward flexed pose, you're stretching your arms out. Move that lactic acid around. When you're not doing endoscopy, you got to start training your body to handle what's a very rigorous exercise. Women respond just as well to strength training as men. It's important to think about advocating for physical therapy and ergonomic assessment within your institution. So my take-home points are, remember that gorilla, right? Remember that gorilla in the room. You matter. Take an ergonomic timeout. Watch your trainee. Have people watch you, advocate for ergonomics, and train your body outside of work. All right, so if you have any further questions, collaborations, concerns, feel free to reach out anytime. This video on the bottom here is exceptional at going through the C formation. I would encourage everyone, it's the best 27 minutes you're gonna spend if you do colonoscopies. It was done by my mentor who taught me some principles and teach the trainer, not ergonomics, but I think it's very, very helpful if you wanna adapt the C loop position. And I'll take any questions.
I have a question and a couple of comments. I thought your talk was terrific and makes me really glad that I stopped doing procedures years ago. But my first comment is that I'm part of a tradition from the University of Kansas and the University of North Carolina and we have all agreed never to mention the name of the men's basketball team at your institution. The other comment is that I've always been struck in medicine that physical training is it's virtually ignored. And I noticed even in your talk, you sort of mentioned it almost as a throwaway suggestion. And I'll come back to that in just a little bit. But
Sure.
I've also been struck that you don't see people warming up before they're doing something in medicine, whether it's as simple as drawing blood, doing the colonoscopy, whatever. But if you think about it, when was the last time you saw an athletic event where nobody warmed up?
Yeah, I think, yeah, thank you so much.
I have for you though, what would you think about spending time visiting the men's basketball program and the women's basketball program at your institution? And the reason is that an average university basketball program involves 30 games a year, and the games last 40 minutes. So that means all the time that's spent in training and working out is for 20 hours. And you look at how important that must be to the basketball program, and I would think that you might get some ideas that could help you not only with focusing on colonoscopy, but focusing more broadly on procedures in general. And thank you.
Thank you so much. Yes, part of the reason I didn't express the specific training plan is it does kind of depend on where you're starting from, right? So if you're in cervical flexion, cervical extensions, whatever your issues are, that kind of dictates how you get to neutral posture, right? So it's not a one size fits all. But I completely agree with you that I think it's incredibly important. I think there's a study coming out from the Mayo where they've done like yoga-based training. That's not something that I personally do. But I will tell you, when I'm driving into work, I use my muscle rubber bands as I'm stuck in traffic because I am warming up for my scoping for the day.
Thanks, Sahar. This is Sarah Street. What a fantastic talk, as I just did 12 cases and my hands are just killing me on the way home. But I had a question. You like the clear cap, it sounds like, and I wonder if you use it on essentially everyone. A lot of us at Stanford have the rubber endo cuff, which I think frustratingly sometimes feels like it drags on the way in. Do you use that at all? And if you would comment.
I do not use the endo cuff. I think it can be helpful. I'll tell you what I use the cap for. I use the cap first of all, the cap basically, it takes a little bit of adjusting to because you might have to adjust a little bit your lighting because sometimes the light deflects inside the cap. So you want to just have a very small rim of the cap showing. It has the same effect of the cuff in that it helps retract the tissue, but it's much less of a kind of like a big giant thing that's kind of obstructive for you. I find that the caps are incredibly helpful if I have an EMR, if I have hurting hands and I anticipate the colonoscopy is going to require a lot of this maneuvering in order to look between all the crevices, because essentially what the cap does is it peels away the fold. So I just have to tip deflect into that location. So I would recommend, if you're already using the endo cuff, to consider using the cap. You just want the little hole of the cap aligned with where your lens is, just a very small rim showing. And particularly if you use water immersion, I think you'll really, really like it. I don't use it in all my cases, but I definitely would say I use it in about 20% of my cases.
Hi, Sahar. Thank you. This was a great talk and definitely eye-opening for me, I have to say. I have a question regarding, you mentioned what's needed for the institutions in terms of the room dynamics and for us in terms of being aware of our position. But are there any data in terms of the number of the procedures that are more likely to put you at high risk and the type of the procedures. Specifically, I'm interested to know if we know having women on your schedule are more likely to increase your risk of injuries because of what we have with the women. Is there any data on that end, or are there any recommendations in terms of how many procedures are safe for us to do, and how should we space them out, and what are the terms to really decrease the injuries?
Yeah, I think those are really great questions. So I did not put the slide in, but I have this wonderful slide where I show you the number of PubMed publications on those sorts of topics versus bowel prep, and it's like 20 versus 4,000, because we don't study ourselves, we don't value ourselves, and the industry doesn't really care, right? Like, it's not something that's prioritized. But the older studies used to say more than 20, but come on, like, we all do more than 20 colonoscopies in a week. None of us can make our paycheck if we, you know what I mean? Like, that's ridiculous. You know, that's what people are doing, some people are doing per day. So I think that's not realistic. I think your point to the fact that, remember, the amount of time that you're doing a colonoscopy, the longer that colonoscopy stretches on, the higher the lactic acid buildup, the higher the recovery time, the higher the risk to injury. So I think there's something to be said about the degree of difficulty, what are the difficult colons, the amount of exposure you have, and to that danger and getting injured. And I don't think we have a lot of data on that. And I think it's a really, really important question. I would love to collaborate and do a study, because I even have I work with like 5 different engineering teams here at Duke. They like basketball, but they also like to be innovative. And so we're working on a suspension scope stand. We're working on a joystick device to work on kind of offloading. But if you guys have any interest, we are always interested in working together. But I think it's a really important question. I'm sorry, I don't think we have a lot of answers out there.
Thank you.
Of course, thank you.
Can I ask one more?
Ask away. I love these questions. Absolutely.
Okay, great. So you mentioned, is it Olympus that has a pilot that shows essentially like a fluoro, I forget what it's called, that basically.
Oh, yeah, the scope guide. Yeah. So it does have that. It has that feature. I think you guys have Olympus. I think it's in specific Olympus scopes. I don't know if it's only the adult scopes. I know before it wasn't in the pediatric scopes, but if ever you guys want, I can workshop with you guys. I have a whole other thing that I do with Teach the Trainer on how to identify looping outside of the scope guide, because I haven't had a scope guide in like 8 years, and happy to help you guys in any way. One of the things that I would say to you guys is, I think you're in between deciding Olympus, Pentax, and Fuji. And that's a whole other area that I'm happy to help you guys with, because we just I was at UCSF as I used Olympus, then I came to Duke and I used Pentax, but without even a stiffener. It was old school Pentax. And then they decided to use the Fujis, but we got to trial both the Pentax and the Fujis. So I'm happy to give some guidance. I think there's pros and cons with that. I do think, though I make zero profits out of this, that the ergonomic changes to the Pentax scopes are slightly better. I don't know if Olympus has made any adjustments, but they made the dials flatter and more accessible. But I defer to you guys to give it a feel. But this is great. This kind of discourse is so vital. And like a lot of the ergonomic talks that I see, they don't actually go through practical solutions or where you think people are hurting. It just keeps showing that same image. It's like, you need something concrete to work off of, right, when you're in the room. So I think these conversations are so important for faculty to get trained on. Oh, at one point, have there been any developments in suspended lead vests? I'm not aware of that. Are there developments in suspended lead vests? That sounds pretty cool. We're working on a suspended scope holder for you guys, which I think will be amazing, because it'll offload the weight of the EUS scope. I used to do EUSs and ERCPs. I gave that up. but yeah, it's a great question. I'm not aware of that. I'm sorry about that, Matt, but great question. Thank you guys for all the encouragement. And I see Edith Ho there, which I'm so excited about. She was one of my prior fellows.
I was going to say that I learned endoscopy from Sahar when I was a fellow at UCSF when you were an attending. So thank you very much for all your help.
Oh, yeah, of course. But
yeah,
anyways,
thank you so much for your talk. That was very helpful.
No worries.
Really interesting. Yeah.
Yeah,
I have a question for you about posture. So I
Yes.
find myself when I do colonoscopy that I sometimes lean my hip on the stretcher, and that relieves some pressure on my lower body, but then that ends up arching my back. So is that I mean, I try not to do it for long periods of time, but is that something that I can use just periodically to relieve pressure in my lower body, or is that a posture that I should really avoid?
Right. So I guess what I would ask you is, so again, I'm not a physical therapist, disclaimer. May I ask you which hip?
Both.
Both hips. And can I ask you, do you hold the scope off the bed?
I do. Sometimes I try to. Oh, you mean the C position, or you mean
do you typically hold the scope off the bed?
I would say half the time I hold it off the bed.
Yeah. So I definitely think there would be do you guys have anyone there that does ergonomic evaluations at all? No. So I think that's where that might be of value to get an assessment, because a lot of times we would want to see your whole body mechanics. The things you want to pay attention to are, is there a position where you're putting the water pedal, which is preferentially making that one hip come forward? Do you have small children at home, which makes you kind of like lean back a lot? And so you're compensating by bringing the one leg forward. So honestly, there's not a one size fits all solution. But I would say if you can start with just athletic pose and trying to keep the scope on the bed, I think that would be helpful. But I would definitely just try to get an ergonomic evaluation. I'm trying to think if there's anyone out there. I know someone here in North Carolina who's awesome, and she can always come out to your institution.
Great, thank you so much, Sahar.
Thank you. I have a quick question for you.
Yeah.
So I found a whole bunch of things which I could do differently, and your talk was great. My question is, if I've been lucky enough to never have any issues with it whatsoever, and I don't have any discomfort, do I change things just to change them, or is somehow my combination of bad habits somehow working fine, and I should just stick with it if I'm not if this has been 20 years and I've had no issues?
Yes, I would say two things. One is, that's amazing. Good for you. That's awesome. Part of it is understanding that what your practice is like, right? So if you're predominantly upper endoscopy, you might not have the same pain points, right? So if you're someone whose main practice is upper endoscopy, not colonoscopy, it's a very different strain on your body. And then the second thing is, I would say, is we want to teach our trainees differently than how perhaps we do it, so they have the resources to start in neutral. So I think that's one of the things that I learned is, this was really hard on me because I had to unlearn how I was doing endoscopy, which was very difficult for me. But kind of making a commitment that I'm going to teach them a certain way how to do it, because that keeps their body in neutral. So the C scope, if there's a way to consider incorporating that from the perspective of, look, I want you moving forward to have this skill set as the way you do it, so that you are protected and being consistent in it. And I would say, I'm grateful that you're not injured, but perhaps your practice is different than someone else's practice.
Yeah, it's fair. It's fair. It makes, yeah, it sounds good. I'm mostly top down and less colon, so I think that's probably the reason.
I think the static work, I think the work is just very different, because there's a lot more of this, right? And I think that's where people come out of alignment. Whereas with upper endoscopy, you basically do tip deflection, and then you just use your hand to give you rotation. So you're basically doing a C-loop position in upper endoscopy naturally. But yes, and then what is the ideal type of ideal location. Okay, I switch the water pedal left and right. I switch them, and I make my surgical techs yell at me if I don't, because then you start favoring your hip in the right. You basically start to, those people who have pain in their right foot and their left hip. It's or it's because of that positioning, that forward leaning. So I intentionally go side to side, and I make sure I'm in the middle of the mat. I don't want to be on the edge of the mat, because if I'm on the edge of the mat and my water pedal is on the edge of the mat, it's like I'm standing in 3-inch heels. So just be mindful of these little things are big deal things. These little things, right? Is the mat all the way, is the bed all the way onto the mat, so I'm not standing on the edge of the mat, but in the center of the mat, right? Is the monitor come down? Even something as simple, guys, even as simple as the doors in your unit, making sure they're not excessively, we have these doors they install in our buildings, which I took a device to, weighed 18 pounds to pull. And everyone said, look at these beautiful glass doors that we built you to, doors that you open to go in and talk to the patient for pre and post. And I'm like, I'm not pulling 18 pounds, 40 times a day to open a stupid door. Like, this is ridiculous, right? So, but people, these are things that people don't think about, these micro traumas over the course of a day, right? Your keyboard, having that mouse, that number pad in your shoulder, and always in abduction, right? This is going to start to hurt when you're always like this, when you're trying to reach for your mouse. So it's all these micro traumas, Let me see, any other questions? Thank you so much for asking these questions. Oh, pros and cons of doing colonoscopy in a sitting or an adjustable stool. Get the ophthalmologist stools, which is like almost like you're not really sitting, you're kind of like perching. So it's kind of like half sitting, half you're kind of perching, because if you sit and your posture is like this, you're not helping yourself. You kind of have to be like back straight, ears over your shoulders, right? Ears over your shoulders. If your ears are forward, ears are back, So like the stool posture, if you have poor core, this defeats the purpose of offloading your feet. Don't do it. Most of us have poor core. All right. What is the ideal? Anything else, guys, before I leave you guys? This was awesome. Thank you so much for letting me talk to you guys. I so appreciate it. This is something I really value, and please reach out with any other questions, any other resources I can send your way. I want the talent to be safe. You guys are the priority.
Thanks. Appreciate it, Sahar. Thank you very much.
Thank you so much, guys. Take care.
Bye.
Bye.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.